This REMS is for extended release or long-acting opioids, and the title is Achieving Safe Use While Improving Patient Care. There's information regarding me. I am a family physician and practice emergency medicine some also. I'm a graduate of Auburn and the University of Alabama in Birmingham, and I am certified in family medicine. I went to Northeast Alabama Regional Medical Center in Anston, Alabama for my training, and I'm currently practice family medicine in Clay County, and I'm on the staff of multiple hospitals around the state. And my current office here is I'm chairman of the Board of Medical Examiners, and I'm chair of the Medical Association of the State of Alabama. As you can see, on July 29, 2012, the Food and Drug Administration approved a REMS mitigation strategy for extended release and long-acting opioids. And this course comes from an institution called CORE, Collaborative for REMS Education. And these acknowledgments. This is a list of the drugs that are covered by this talk. I'm not going to go through all of them, but particularly some of them that are important are Avenza, Duragesic, Cadian, Methadone, MS-Contin, Nucena, Opana, and OxyContin. And there are multiple generic drugs available in this class also, particularly fentanyl, methadone, and morphine. Why is prescriber education important? On Advancing Pain Research, Care, and Education, in its most recent report, found that effective pain management is a moral imperative, a professional responsibility, and the duty of people in the healing professions. However, they also recognize the conundrum of opioids. The committee recognizes the serious problem of diversion and abuse of opioid drugs, as well as questions about their long-term usefulness. However, the committee believes that when opioids are used as prescribed and appropriately monitored, they can be safe and effective. ERLA opioid analgesics are indicated for the management of moderate to severe pain when a continuous around-the-clock opioid analgesic is needed for an extended period of time. ERLA opioid analgesics are not indicated for use on an as-needed analgesic for mild pain or for pain that's not expected to persist for an extended duration or for the use in treating acute pain. ERLA opioid analgesics are controlled substances in Schedule II or Schedule III with abuse liability similar to other opioid agonists. Schedule II and Schedule III opioid substances have high potential for abuse and risk of fatal overdose due to respiratory depression. ERLA opioid analgesics can be abused in a manner similar to other opioid agonists, licit or illicit. This should be considered when prescribing opioid analgesics in situations where the prescriber is concerned about an increased risk of misuse, abuse, or diversion. According to the Controlled Substance Act, these drugs have a useful and legitimate medical purpose and are necessary to maintain the health and general welfare of the American people. At the same time, improper use of controlled substances has a substantial and detrimental effect on the health and general welfare of the American people. In the Practitioner's Manual, the Drug Enforcement Administration states, "It is important now than ever to be vigilant in preventing the diversion and abuse of controlled substances. As a practitioner, your role in proper prescribing, administering, and dispensing of controlled substances is critical to patients' health and to safeguarding society against the diversion of controlled substances." Opioid misuse is a big problem. I believe yesterday I would hope would show you that. The two main populations in the United States at risk for prescription drug overdose are the approximately 9 million persons who reported long-term medical use of opioids and the roughly 5 million people who report non-medical use, in other words, use without a prescription or medical need in the past month. Improper use of any opioid can result in serious adverse events, including overdose and death. However, the risk for overdose and death is greater with extended-release opioids because these agents contain a larger opioid dose in a single dosage unit. Individuals taking methadone, which is the long-acting opioid, are also at greater risk. More than 30% of prescription opioid deaths involve methadone, even though only 2% of painkiller prescriptions are for this drug. Methadone is increasingly prescribed as a painkiller because it is a generic drug that can provide long-lasting pain relief and is available as a low-cost generic. But as methadone's use for pain has increased, so has non-medical use of the drug and the number of overdoses. Methadone has unique risk. The difference between appropriately prescribed doses and dangerous doses of methadone is small. Taking it more than 3 times a day can cause the drug metabolites to accumulate in the body, and methadone can disrupt the heart's rhythm. In 2011, 34.2 million Americans aged 12 or older had used a prescription opioid analgesic for non-medical use sometime in their life. This figure was the same for the past year and also for the past month. In 2010, 425 million drug-related emergency department visits were attributed to misuse or abuse of prescription opioid analgesics. This is a 156% increase since 2004, when there were approximately half that number of visits. Drug overdose death rates in the United States have more than tripled since 1990 and have never been higher. In 2008, 36,450 people died from drug overdoses, and most of these deaths were caused by prescription drugs. Almost 75% of prescription drug overdose deaths were caused by prescription opioids, more than cocaine and heroin combined. For every 1 death, there are 10 treatment admissions for abuse, 32 emergency department visits for misuse and abuse, and 130 people who abuse or who are addicted, and 825 non-medical users. The rise in overdose deaths in the United States parallels a 300% increase since 1999 in the sale of opioid analgesics. About half of prescription opioid deaths involve at least one other drug, including benzodiazepines, cocaine, and heroin. Alcohol is also involved in many overdose deaths. The slide shows the first-time use of specific drugs. In 2011, the National Survey on Drug Use and Health found that the drug category with the largest number of recent initiates among persons aged 12 or older was marijuana, followed by non-medical use of painkillers, non-medical use of tranquilizers, ecstasy, and inhalants, cocaine, and stimulants. This is our learning objectives for this course. Appropriate prescribing practices and patient education are important steps to help address this public health problem. Healthcare professionals who prescribe ERLA opioid analgesics have a responsibility to help ensure the safe and effective use of these drug products. The expected results of this REMS education are that the prescriber will understand how to assess patients for treatment with ERLA opioid analgesic products, be familiar with how to initiate therapy, modify dose, and discontinue use of ERLA opioid analgesic products, know how to manage opioid ongoing therapy, know how to counsel patients and caregivers about the safe use of ERLA opioid analgesic products, including proper storage and disposal. Be familiar with general and product-specific drug information concerning ERLA opioid analgesic products. Assessing patients for treatment with ERLA opioid analgesic therapy. Balancing risk against potential benefits. Before initiating any chronic opioid therapy, clinicians should conduct a history, physical examination, and appropriate testing, including an assessment of risk of substance abuse misuse, or addiction. Clinicians may consider a trial of chronic opioid therapy as an option if chronic pain is moderate or severe, has failed to adequately respond to indicated non-opioid and non-drug therapeutic interventions, and is having an adverse effect and impact on the function or quality of life, and potential therapeutic benefits outweigh or are likely to outweigh potential harms. The ethical imperative is to provide the pain treatment with the best benefit to harm profile for the individual patient. A benefit to harm evaluation includes a history, physical examination, and appropriate diagnostic testing, which should be performed and documented before and on an ongoing basis during chronic opioid therapy, and clear and measurable treatment goals should be established. Proper patient selection for a trial of opioid therapy is critical and requires a comprehensive benefit to harm analysis in the recognition that an opioid trial may not be appropriate. Through risk assessment and stratification is appropriate in every case. This approach is justified by the estimates of aberrant drug-related behaviors, drug abuse, or misuse in patients with chronic pain, which range from 0 to 50%, depending on the population evaluated and the methods used to define and identify these outcomes. Risk stratification pertaining to outcomes associated with the abuse liability of opioids, misuse, abuse, addiction, and diversion is a vital but relatively undeveloped skill for many clinicians. However, all clinicians prescribing opioids should be knowledgeable about risk factors for opioid abuse and methods for assessing risk. Assessment of risk for opioid assessment adverse events also should be performed, given their high prevalence. Risk involved with ERLA opioid analgesics include overdose, as most dosage units contain more opioid than in immediate release formulations, abuse by patient or household contacts, misuse and addiction, physical dependence and tolerance, interaction with other medications and substances, inadvertent exposure by household contacts, especially children. Because opioid therapy carries risk and can cause harm in some individuals, the safe and effective use of opioid therapy requires that prescribers document all patient interactions, assessments, test results, and treatment plans. The clinical interview. Patient medical history. A comprehensive patient assessment should be completed to identify clinical conditions that may interfere with the appropriate and safe use of opioid therapy. Pre-existing constipation, nausea, pulmonary disease, and cognitive impairment probably predict risk for opioid-related adverse events, though no studies have adequately evaluated the utility of these factors for use in risk stratification. Patients with sleep apnea or other underlying pulmonary conditions may be at higher risk for respiratory depression. Significant respiratory depression is a contraindication to ERLA opioid therapy, particularly in unmonitored settings, and acute or severe asthma are relatively contraindicated in opioid therapy. COPD patients may have decreased respiratory drive with opioid therapy. This is not an absolute contraindication. However, extreme caution should be used. Obstructive sleep apnea patients who do not use CPAP are at increased risk of further desaturation with the use of opioids, which may cause central sleep apnea. Patients on CPAP with sleep apnea may experience additional opioid-induced central sleep apnea with opioids. Patients with sleep apnea should be adequately treated for their sleep apnea before the initiation of chronic opioid therapy. Patients with symptoms suggestive of sleep apnea should have a sleep study prior to initiation of opioid therapy. Hepatic and renal disease are relevant to the metabolism of opioids and may alter the recommended dosing of opioids. Medical illnesses possibly linked to substance abuse include hepatitis, HIV, tuberculosis, cellulitis, sexually transmitted diseases, trauma, burns, cardiac disease, pulmonary disease, which is often due to smoking drugs, although many drug users also are tobacco users, and it's also due to suppression of respiratory and cough reflex. Multiple strategies can be used to determine pain intensity, pain-related disability, and distress. Interviews, standardized questionnaires, diaries, behavioral observation, psychophysiologic assessment, and discussion with family members and significant others are commonly used to investigate and quantify pain experience and concomitant physical and emotional function. A well-conducted clinical interview can be a rich source of information regarding a patient's pain and pain treatment history, as well as the resulting physical, emotional, behavioral, and cognitive responses. The interview also provides an opportunity for clinicians to interact with the patient, to establish rapport, and to develop an impression of the patient's receptivity to rehabilitation and treatment efforts. Questionnaires and inventories provide opportunities for focused assessment of specific domains of functioning and quantifying patient responses. Because published questionnaires have typically met standards for reliability and validity, greater confidence can be placed in the information provided by these means. Questionnaires typically permit quantification of important dimensions of the experience of pain that allows for evaluation within a person change over time. Even when conducting an unstandardized interview, it is used to systematically investigate a pre-specified set of domains. For example, location of pain, where in the body, whole body, etc. Intensity of the pain, rating on the 1 to 10 scale. The patient rates their present level of pain. The worse it gets, the best it gets, and the average pain rating. The quality of the pain. Don't prompt, but use the patient's own words when possible. For example, dull, stabbing, burning, shooting, aching, piercing, tingling, numb, radiating. Onset and duration, which is the approximate time the pain started. Variations in the pattern or rhythms. The pain is constant, intermittent, episodic, recurring. What relieves the pain? Sitting, lying down, standing, heat, cold, rest, distraction, exercise, or movement. What causes or increases the pain? Sitting, lying down, standing, heat, cold, rest, exercise, or movement. The effects of the pain: sleep, on movement, energy, lifestyle, personal relationships, work, emotions, concentration, appetite, motivation, activities of daily living, ADLs, and instrument activities of daily living, IADLs. Patient's pain and function goal. In other words, what do they want to get out of this? Sleep comfortable, comfort at rest, comfort with movement, perform a certain activity, be able to do ADLs, be able to increase their quality of life. Acceptable rating of their pain. The benefits of chronic opioid therapy are most applicable to patients with moderate or more severe pain who have not responded to non-opioid therapies. Information from the pain history and physical examination should be reviewed to ensure that the patient has an adequate therapeutic trial of non-opioid medical therapies. Since in many cases opioids may be recommended only after alternative pain control methods have been attempted, information regarding an individual's response to past pain treatment efforts is essential. It is important to evaluate not only which treatments have been tried, but also to determine the dose and length of the treatment. Some patients may report therapeutic failure when they have actually not experienced an adequate therapeutic trial of the treatment option. Of particular relevance is any information regarding past opioid treatment, including adherence, adverse events, outcomes. Previous opioid therapy failure may warrant strong consideration of not undertaking additional trials. During the interview, it is important to determine the current use, dosage, and general effectiveness of pain medications to determine patient perception of effectiveness. For opioids, the currently prescribed opioid dose, regimen, and duration are important to determine if patient is opioid tolerant, as defined by the FDA. Where available, prescribers should query state prescription drug monitoring programs, in other words, the PDMP, to confirm the patient's report of controlled substances prescribed and who was prescribing them, and determine if he or she has been doctor shopping. Contact past medical providers to confirm the patient's self-report is also useful, and to obtain prior assessments, diagnostic studies, and test results. A urine drug test should be used to confirm the presence of prescribed drugs or to identify illegal drugs or unreported prescribed medication. It is also important to know all drugs taken, as other drugs co-administered with opioids may result in adverse drug interactions. For example, concurrent sedative use may also cause cognitive deficits in patients on opioid therapy. Benzodiazepines have been shown to also increase the risk of central sleep apnea with methadone. Benzodiazepines have also been shown to be associated with an increase of death due to methadone toxicity. The use of fentanyl with cytochrome P450 inhibitors, for example, ketoconazole, erythromycin, grapefruit juice, and rapamycin, may increase plasma fentanyl concentrations, increasing or prolong adverse drug effects, and may cause potentially fatal respiratory depression. Agents that prolong QT intervals on electrocardiogram may increase the risk of QT prolongation and torsade de pointe with methadone. A history of non-pharmacological strategies of effectiveness should be evaluated. In other words, things like physical therapy, surgery, psychotherapy, relaxation, biofeedback, manual treatments, TENS units, heat application, cold application, occupational therapy, exercises, and stretching. Perform a thorough evaluation and assessment of the pain. The physical examination serves to further explore the findings from the clinical history and to help confirm the diagnosis. Objective data obtained from the examination is important to adequately diagnose the etiology of the pain. A structured approach to the physical examination includes the following key components. Select those appropriate for the pain location. A general physical exam including vital signs, and observe the general appearance and gait of the patient. Attributes include how the patient dresses and personal hygiene. Note pain behaviors, posture, and anatomic abnormalities. A pain-focused neurologic examination may involve a mental status exam, cranial nerve testing, motor strength evaluation, deep tendon reflexes, sensation coordination. A pain-focused musculoskeletal examination of the spine and the extremities with their respective joints. The format involves following the steps of inspection, palpation, percussion, auscultation, and provocative maneuvers. And it serves to evaluate integrated functioning of bones, joints, supported ligaments, and muscular tissue. It's used to localize possible sources of pain in various structures. An examination for cutaneous or trophic findings. The following suggests possible drug use: abscesses, cellulitis, tissue necrosis, parallel needle marks, hyperpigmentation overlying a vein, palpably sclerotic veins, trauma to the skin such as abrasions, lacerations, or cigarette burns. The physical examination may be helpful in elucidating the etiology of a patient's pain complaints. However, used alone, it has the limitations, and the results of a physical examination need to be considered in the context of the patient's history, as well as in the context of the results of diagnostic studies. Clinicians should obtain appropriate diagnostic tests to evaluate the underlying pain condition and should consider whether the pain condition should be treated more effectively with non-opioid therapy rather than with chronic opioid therapy. For example, this generally would not be appropriate before a trial of anticonvulsant for trigeminal neuralgia, a disease-modifying anti-rheumatic drug for rheumatoid arthritis, a corticosteroid for polymyalgia rheumatica, or various abortive or prophylactic medication for migraine assess the risk of abuse, including substance abuse and psychiatric history. Before initiating opioid therapy, clinicians should assess risk of substance abuse, misuse, or addiction. Proper patient selection is critical and requires a comprehensive benefit to harm evaluation that weighs the potential positive effects of opioids on pain and function against potential risk. Though risk assessment and stratification is appropriate in every case, this approach is justified by estimates of aberrant drug-related behaviors, drug abuse, or misuse in patients with chronic pain. And these range from 0 to 50%, depending again on the population evaluated and methods used to define and identify these outcomes. A thorough assessment of psychosocial factors and family history is essential for adequate risk stratification. The history of current and past drug substance abuse should include prescription drugs, illegal substances, alcohol, and tobacco. Social history, including employment, cultural background, social network, marital history, and legal history, including other behavioral patterns, are also relevant. For example, unresolved compensation or legal issues may predict poor response to all therapies, including opioids, and patients with an unstable or dysfunctional social environment require additional monitoring during treatment. A substance abuse history does not prohibit treatment with ERLA opioids in every case, but may require additional monitoring and assistance from persons with expertise in managing pain, addiction, or mental health concerns. In some cases, opioids may not be appropriate or should be deferred until the comorbidity has been adequately addressed. It is also important to ask about family history of substance abuse and psychiatric disorders. The ORT scale also notes pre-adolescent sexual abuse makes patients higher risk for opioid misuse in women. All clinicians prescribing opioids should be knowledgeable about risk factors for opioid abuse and methods for assessing risk. The factor that appears to be most strongly predictive of drug abuse, misuse, or other aberrant drug-related behavior after initiation of chronic opioid therapy is a personal or family history of alcohol or drug use. Younger age and presence of psychiatric conditions are also associated with aberrant drug behaviors in some studies. A variety of self-administered and provider-administered screening tools based on patient characteristics are helpful for risk stratification. In other words, identify an individual's patient's risk in order to make informed prescribing decisions when prescribing a drug with abuse liability and to develop a treatment plan that accommodates that risk. These screening tools differ in their psychometrics and intended uses, and not all have been validated for use in chronic pain patients seen in the clinical practice setting. Several tools assess abuse potential, in other words, predict risk, among patients being considered for chronic opioid therapy. Other measures are designed for use in the pain management setting to characterize the degree of medication misuse or the aberrant behavior that characterizes the patient's opioid use once he or she has been taking opioids for some length of time. Patients sometimes underreport drug use to medical professionals, so tools such as a urine drug screen may provide more accurate information than patient self-report, or may verify a patient's self-report. It is important that the clinician understand the limitations of the urine drug testing. While it is a tool that may assist in identifying substance misuse or addiction in combination with a clinical history or other clinical tools, it does not in itself diagnose a clinical substance disorder or addiction. This table is a list of some risk assessment tools. All of these are applicable, can be used in your office. Several tools are available to assess abuse potential among patients being considered for chronic opioid therapy. These tools include the Screener and Opioid Assessment for Patients with Pain, referred to as SOAP, the Diagnosis and Tractability Risk and Efficiency Instrument, or DIRE, and the Opioid Risk Tool, ORT, which appear to have good content, face, and construct validity. Dyer is clinician administered and is designed to assess potential efficacy as well as harms. The SOAP and ORT are patient self-report questionnaires that assess risk of aberrant drug-related behaviors. A review of tools that found that SOAP has the best psychometric properties and may be particularly effective in high-risk settings. The ORT is a brief 5-question measure to classify a patient as high, medium, or low risk for misusing opioids. It may be better suited for primary care settings that have a predominantly low-risk patient population. Of the other measures designed for use in the pain management setting, many are intended to characterize the degree of medication misuse or the aberrant behavior that characterizes the patient's opioid use once he or she has been taking opioids for some length of time. These include pain management questionnaire, the prescription drug use questionnaire, and the current opioid misuse measure. Most screening tools, however, are more suitable to assess current alcohol or drug abuse rather than the potential for abuse. These tools include the Relax Alone Friends Family Trouble, or RAFT, the Cut Down Annoyed Guilty Eye Opener tool adjusted to include drugs, which is the acronym CAGE-AID, and the Drug Abuse Screening Test, or DAST. Most screening intervention, brief intervention, and referral to treatment, which is SBIRT, is a public health approach to the delivery of early intervention and treatment services for persons with substance abuse disorders, as well as those who are at risk for developing these disorders. The typical screening process involves the use of a 1 to 3 question screen, such as the National Institute on Alcohol Abuse and Alcoholism single question screen, or the National Institute on Drug Abuse's quick screen. If a person screens positive on one of these instruments, then he or she is given a longer alcohol or drug use evaluation. As necessary, this is followed by a brief intervention focused on increasing insight and awareness, or referral to treatment for those identified as needing more extensive treatment with access to specialty care. By recognizing the psychometrics and other features of each tool, clinicians can select the one most appropriate for screening ongoing assessment for their particular population. No screening tool or lie detectors. Patients determined to misrepresent themselves will still do so. Other clinical information be used with scores to decide on a particular patient's treatment. This is the opioid risk tool. Note the increased risk for the age 16 through 45. That's an important note to remember. This is the ORT, a brief 5-item self-administered tool to classify a patient as high, medium, or low risk for misusing opioids prescribed for pain. Domains measured are personal and family history of substance abuse, age, history of pre-adolescent sexual abuse, and certain psychological diseases. The scores are weighted according to gender. The ORT may be better suited to primary care settings that have a predominantly low-risk patient population. It is commonly believed that risk is uniform across age groups, but that is not so. The SOAP, again, is another assessment tool. It's a brief questionnaire designed to help prescribers evaluate patients' relatively risk for developing problems when placed on long-term opioid therapy. The SOAP score, along with other clinical findings, can help the provider make a risk-benefit assessment with regard to use of opioid therapy. Each provider will have a different level of comfort and different level of resources in dealing with higher-risk patients. The tools help prescribers to address important questions when treating chronic pain patients. Is long-term opioid therapy a reasonable option? Should you take extra precaution with this patient? What level of monitoring may be necessary to safely proceed with long-acting opioid therapy? SOAP tools are a brief paper and pencil questionnaire completed by the chronic pain patient being considered for opioid therapy. A patient can complete the questionnaire in the waiting room, examination room, or prior to the health visit. Providers, provider assistants, nurses, psychologists, or office staff can administer the tool during the visit, but most patients can complete the questionnaire unaided. It's simple to score, useful to document the decisions about the level of monitoring for a particular patient or justifying referrals to specialty care. Clinicians should have a completed and scored SOAP while making opioid therapy treatment decisions for chronic pain patients. A screening measure like the SOAP generally endeavors to minimize the chances of missing high-risk patients. This means that patients who are truly at low risk may still get a score above the cutoff. In other words, the SOAP is better at identifying who is at high risk than identifying who is at low risk. The SOAP score, along with other clinical findings, clinical observation, medical records, family reports, family history, and data from the drug screen, can help the provider make a risk-benefit assessment with regard to the use of opioid therapy. If opioid therapy is being considered as a treatment option, the SOAP can help the provider determine the level of monitoring that may be necessary for safety in a given patient. Each provider will have a different level of comfort and/or resources in dealing with higher risk patients. Clinicians are recommended to have conversations with their patients about the risks and benefits of opioid therapy and to review the answers on the SOAP questionnaire. Based on their scores, patients can be categorized into 3 distinct groups: low, medium, and high risk. The SOAP score, along with clinical findings, can help clinicians determine the most appropriate pain management regimen for a given patient. For example, an individual who scores a 9 on the SOAP is initially considered in the moderate risk category. After additional evaluation, a clinician may determine that the patient is more likely at low risk and develop a pain management regimen accordingly. However, other history and physical examination may make the clinician classify the patient as high risk. In that case, the treatment plan would reflect this as heightened concern. As with any screening tool, the SOAP may have false positives and false negatives. As the provider gains experience with the particular patients, the provider's view of how vulnerable the patient is to aberrant behavior will be continually revised and refined. Notice it comes in 4 different versions, a longer version and a short version. They all utilize questions that use a scale to 0 to 4. SOAP version 1 is available in 3 formats of 5, 14, and 24 items. The shorter SOAPs were developed for clinicians who have limited time with patients. Questions in the shorter forms are original questions found in the 24-item form, but the sensitivity and specificity changes as one moves from a longer to shorter. So SOAP version 1, 24 question, the original version, consists of 24 questions, 14 which have been empirically identified as predicting aberrant medication-related behavior 6 months after initial testing. To score the SOAP, add the ratings of those 14 questions that are used to score the tool. The 10 unscored questions provide additional background on the patient to the prescriber. A score of greater than 12 indicates a high misuse risk. 8 to 11 indicates moderate risk, and less than 8 includes low risk. It takes less than 10 minutes to do this. SOAP version with 14 questions includes the 14 scored questions from the full-length SOAP with the same parameters. And the SOAP with 5 questions consists of 5 scored questions from the full-length SOAP, all of which are scored. A score of greater than equal to 4 indicates increased risk of misuse. For clinicians with limited time, it takes less than 5 minutes to complete. In general, however, there is a trade-off between the length of a questionnaire and the accuracy as a screener. To achieve a shorter form, the sensitivity, specificity, positive predictive value, and the negative predictive value are lower than in the 14-item scoring. But the 5-item version retains most of the predictive validity. Thus, the SOAP version 1 short form appears to strike a reasonable balance between length and ability to detect future aberrant behavior. The 24-question version is a revised version of the SOAP that was developed to contain more subtle items that are less susceptible to overt deception than the original SOAP. This consists of 24 questions, all of which are used to score the tool, and a score greater than 22 indicates high misuse risk. 10 to 21 indicates moderate risk, and less than 9 indicates low risk. Again, this version takes less than 10 minutes. When to consider a trial of an opioid. ERLA opioids are indicated if pain is moderate to severe in a patient who has failed to adequately respond to indicated non-opioid and non-drug therapeutic interventions, and a continuous around-the-clock opioid analgesic is needed for an extended length of time. Prescribers should consider a trial of opioid therapy when potential benefits are likely to outweigh risk, and that there is no alternative therapy that is likely to pose as favorable a balance of benefit to harm. Consider referral to a pain management or addiction specialist for patients in whom the risk outweigh the benefits. For patients who are known to have a past or current substance abuse problem, an addictionology consultation is recommended before instituting chronic therapy with any scheduled medication. Presence of poorly defined pain conditions, a likely somatoform disorder, or unresolved compensation issues may predict poor response in all therapies, including chronic opioid therapy. We have a couple of examples. In this example, a patient who is 60 years old has chronic disabling osteoarthritis pain despite non-opioid therapies. Immediate relief opioids provided some relief, but he was experiencing end-of-dose failure. His history reveals no significant psychiatric comorbidities, major medical comorbidities, or personal or family history of drug abuse or addiction. He would be assessed as having high potential benefits from opioid therapy related to the risk. ERLA opioid therapy could be prescribed to this patient in most clinical settings with routine monitoring. In contrast, this other patient is 30 years old with fibromyalgia and recent intravenous drug abuse, would have high potential risk relative to benefits. Chronic opioid therapy is usually not the first-line drug for fibromyalgia. If it was indicated due to failure of other therapies, in this context, it requires extensive structure, monitoring, and management by professionals with expertise in both addiction medicine and pain medicine, and should be undertaken only if risk can be adequately managed. The selection of patients between these two extremes requires careful assessment and characterization of patient risk and structuring of care to match the risk. In patients with a history of substance abuse or psychiatric comorbidity, this may require assistance from persons with expertise in managing pain, addiction, or other mental health concerns. In some cases, opioids may not be appropriate or should be deferred until the comorbidity has been adequately addressed. Clinicians may consider chronic opioid therapy for patients with chronic pain and history of drug abuse, psychiatric issues, or serious aberrant drug-related behaviors only if they are experienced in the management of such patients and are able to implement more frequent and stringent monitoring parameters. In such situations, clinicians should strongly consider consultation with a mental health or addiction specialist. Patients who meet criteria for a substance use disorder should be referred for treatment of this serious comorbidity. Here's a couple of special considerations. Elderly patients. In properly selected and monitored older patients, opioid analgesics constitute a potentially effective and, for some patients, indispensable treatment as part of their multimodal strategy in the management of various types of persistent cancer or non-cancer pain. The proper positioning of opioid therapy for older patients with persistent non-cancer pain is based on comparing the potential efficacy and risk with those of other modalities and balancing them against the harms of unrelieved pain and potential adverse effects of opioid therapy. However, older patients may have medical problems that may increase the risk of adverse events. Respiratory depression is more likely in the elderly, cachectic, or debilitated patients who may have altered pharmacokinetics due to poor fat stores, muscle wasting, or altered clearance. Frail older persons or those with comorbidities may benefit from more cautious initiation and titration of opioid therapy. Older patients should be monitored closely, particularly when initiating and titrating ERLA opioids and when they are given concomitantly with other drugs that depress respiration. The starting dose should be reduced by 1/3 to 1/2 of the usual dosage in debilitated non-opioid tolerant patients, and the dose should be titrated cautiously in these patients. In other words, start low and go slow. Another example is that older patients are more likely to develop constipation, and so clinicians should routinely initiate a bowel regimen before the development of that constipation. It is also important to assess whether the patient or the caregiver will likely manage the opioid therapy responsibly. It must be stressed that ERLA opioids have to be safeguarded from theft or accidental exposure by others. Children. The safety and effectiveness of most ERLA opioids in pediatric patients below the age of 18 years has not been established, and most of these agents are not indicated for pediatric patients. Remember that. An exception is transdermal fentanyl, which is approved in opioid-tolerant children ages 2 and older. Analgesic trials pose unique scientific, ethical, and practical challenges in children. At the same time, extrapolation of adult doses based on a milligram per kilogram approach also leads to overdosing in some pediatric populations and underdosing in others. Pediatric indications for opioids for chronic pain are primarily life-limiting conditions. Relatively few pediatric patients with chronic pain due to non-life-limiting conditions should receive long-term opioids. Most non-clinical trial studies examining use of opioids in children focus on safe use in inpatient settings where opioids are a common source of harm due to drug error. Pediatric palliative care teams or pediatric pain specialists should be consulted when prescribing opioids to children for chronic pain, or such therapy should be initiated in a specialized multidisciplinary pain clinic, where a multidisciplinary approach to pain management is undertaken and medications are only considered part of the whole treatment. Extra information about adolescent and young adult ERLA opioid use in children younger than 25 years old, they should be put in the moderate risk category at the very least, just because of their age. Pediatric demographic variables related to non-medical use of opioids. Females are 2 times more likely to abuse than males. White, non-Hispanic are more likely. Education, school dropouts, no plans for college. Perceived poor to fair health, hospitalized in the past year, 3 or more ED visits in the past year. Weekly non-medical opioid use, history of major depressive episode, disordered alcohol use in the past year are characteristics common to prescription opioid abuse and dependence. I'm going to give you another example. This is Peter, 25-year-old white male, who presented to your primary care office at 4:45 p.m. on Friday afternoon, 15 minutes before your office is due to close. He is not one of your patients, but states that he needs to be seen right away as he urgently needs a prescription for oxycontin, codone 20 milligram, Q12 hours, which he has been taking for chronic left knee pain as a result of a motor vehicle accident 5 years ago. He also wants a prescription for immediate release oxycodone, 5 milligram, which he usually uses twice a day, which he refers to as his rescue. He explains that he has just moved to the area from a town on the other side of the state. As he is a new patient, you make sure to include a photocopy of his picture ID in the medical record, and you document the history, examination results, and other interview. His history revealed that he had undergone multiple knee surgeries, the last of which was 18 months ago. However, he reports that he still has persistent ambulatory dysfunction and that he has been granted permanent disability. You ask the patient about previous attempts to treat knee pain, including the use of medications, supporting devices, and physical therapy. He states that the extended-release oxycodone was the only thing that works, and that he has an allergic reaction to both acetaminophen and nonsteroidals, while morphine and codeine make him throw up. He had a series of physical therapy sessions, but they were not helpful and made the pain worse. Physical examination of the painful knee reveals no erythema, swelling, bruising, or discoloration. However, surgical scars are present. The left quadriceps has signs of atrophy compared to the right, and the range of motion or flexion of the left knee is limited. You administer the 5-question SOAP tool to assess the patient's risk for abusing prescription opioids. His answers reveal that he has a score of 7, which places him at high risk for misusing prescription opioids. You ask him further about his substance use history, and he admits to smoking 1 pack of cigarettes per day for 10 years, and he claims only to have used marijuana on occasion and not for the last 2 years, and does not misuse his prescription opioids. And what do you do next? You ask Peter for the name, address, and telephone number of his previous regular provider, and of course he claims not to have the information with him, but can provide it Monday if you'll give him a prescription now. You request that Peter provide you with a urine sample for testing. He accuses you of not trusting him, but you explain to him that it is your office policy that part of the assessment for any new patient who is being considered for treatment with a controlled substance is a urine drug screen, and he reluctantly agrees. While Peter leaves the examination room with the nurse to provide a sample, you log onto the computer and access your state's PDMP. You enter Peter's name and date of birth to receive a report that includes his 6-month history of Schedule 2 through 5 history of controlled substances prescribed here in Alabama. This report reveals some concerning information. Peter has received a total of 26 prescriptions for extended-release oxycodone, immediate-release oxycodone, immediate-release oxycodone acetaminophen, and hydrocodone acetaminophen from 4 different providers. Remember, he's, quote, allergic to acetaminophen. The time frame of such situations are important, as overlapping date would constitute doctor shopping. Some prescriptions were paid with insurance, but others were paid for with cash, and there were several filled at different pharmacies. The amount and strength of pills were not consistent. Your nurses collected 2 urine samples from Peter. The first is a point-of-care multi-drug immunoassay test cup that detects the presence of marijuana, cocaine, opiates, methamphetamine, and amphetamine within 5 minutes. The other sample is sent to the testing laboratory with instructions to test using a pain management profile that includes creatinine, oxidant, and pH to detect attempts to adulterate the urine specimen, along with marijuana, cocaine, opiates, and oxycodone. The reason for this second test is because the point-of-care test that you use in your office only detects the naturally occurring opiates like morphine and codeine. As a semi-synthetic opioid, oxycodone is not reliably detected by such an immunoassay, and so must specifically be added to a panel. And presently it is included in some, but not all panels. Always check with your laboratory. Your nurse provides you with the point-of-care drug screen results. It was positive for marijuana and negative for all other substances. Most drugs have a window of detection for about 2 days in urine. Use of lipid-soluble drugs such as marijuana may extend the window of detection to a week and up to even to a month. And chronic users may detect positive for up to a month from their last use. However, this does not account for Peter's positive result, as he claims to have not used marijuana for 2 years. What should you do now? Give Peter a prescription for a 4-day supply of oxycodone to last until you can contact his previous prescriber on Monday. Item 2, explain to Peter that you are unable to provide him a prescription today, as he has lied to you about his been prescribing for him, and about his marijuana use, which has been recent. You are concerned that he has an untreated addiction problem, which will prevent you from being able to address his pain using controlled substances. However, you make a referral to a pain management specialist who is an expert in addiction medicine and will work with that provider to help manage his pain in other ways that are a safer alternative to a controlled substance. The third alternative is to give Peter a 30-day prescription for oxycodone, and IR oxycodone, which will give you time to carry out diagnostic tests on his injury, obtain his prior medical records, and review results from tests, including the laboratory drug screen. What is the right answer? 2. There are several red flags here. The PDMP report revealed probable drug doctor shopping. His drug screen result was positive for recent marijuana use, which he had earlier denied. His SOAP screening questionnaire revealed a score that suggests that he is at risk for prescription drug misuse. The DEA has identified the following modus operandi that are often used by the drug-seeking patient. Wants an appointment toward the end of office hours or comes in after regular hours. Requests a specific controlled substance drug and is reluctant to try a different drug. States that specific non-opioid analgesics do not work or that they have an allergy to them. Is reluctant to give the name of his primary provider. Some reports also suggest that patients who are involved in unresolved disability claims or lawsuits are at higher risk for aberrant behavior or predict a poor response to all therapies, including opioids. Younger age is a risk factor for aberrant behavior. He may well have a genuine pain problem, but for you to attempt to manage this while he has an untreated addiction problem is beyond the scope of your practice as a primary care provider. Referral to a pain management specialist who is an expert at addiction or to an addiction provider are the preferred options. Okay. Thank you.